So the program today, in honor of the 50 years, was designed to be able to kind of take advantage of the holiday spirit as well. And we wanted to bring back some spirits of research past and research future. So when we started thinking about who had an impact on this organization in the past, and who could tell stories about the past, and who could really relate to us all about what it must have been like back in was it the 20th century, 19th century, leading this organization and battling all the odds to create a research program here. And I can think of no one better than to bring back Tom. So Tom, if you could join me up here.
You don't understand.
Exactly. He's got it in. It's ready to go.
I will show you that in a minute.
All right, good. Thank you. So I will say that Tom and I didn't even have a chance to say good morning to each other. So this is kind of fun to actually be able to say hi. And also on the phone, if you made it, was going to be Steve King. So Steve, are you there?
I am. Actually, I can even see.
Oh, hey. Right. So between these two guys, who've got years and years and years and years of experience of leading this organization. So I turn it over to you to regale us now with your stories of past.
Thank you. Thank you. I've never been introduced as Christmas past. But at my age, we're not so sure there's a lot of Christmas future left. So it's really thrilling to be here. I worked here for almost 13 years, and I've been retired 13 years.
Wow.
That's unbelievable, isn't it? Yeah, so the last 26 years of my life have somewhat been associated with the ACR, which has been incredibly valuable to me. So Charlie said, tell us some history. There are some posters along the hall I just saw that I'm going to repeat a lot of that, actually. Don't fact check me because but you'll get the general gist of it. So what I did was to take the old presentations that I have. I never throw anything away. So I went through some old files on my computer and I found some old presentations that I had, and I thought I would show you some of those, and by that relate a little history to you. So the question is, I got off of what does an old retired person do? So here's the answer to that. There you go. That's my job now. That's just a streetcar. It's a Baltimore Streetcar Museum. And I work there on the weekends, and at Christmas I'm Santa Claus. I'm going to do that tomorrow and the next day. So this is actually a Philadelphia streetcar we have in Baltimore.
Wow.
We have pictures of it actually on 11th Street, right by the old office, that real car. Okay, next. And it's really great talking to the children and finding out all the things they want, and they tell me all this stuff, and I have absolutely no idea what it's talking about. And so after we get all the kids off, then I get to run the streetcar, which is a real trip and a real fun thing to do. Okay? So this is something I've made, I think, in 2003. Welcome to the Philadelphia office. I apologize because this is the old ACR logo that will show you how far behind I am. This is the way we started the presentation. Next. So the American College of, this is what I gave to new employees. This is what I gave to, we used to say, visiting firemen, visiting board and chancellor's members, and anybody else that was foolish enough to sit and listen to me. We talked about the ACR as the Professional Association for Radiologists, Diagnostic, Interventional, Radiation Oncologists, and Medical Physicists, and the main office is in Reston. So the question is, next. Again, it's a lot of button pushing.
I think it is.
You know, I'm missing my little remote.
Our clickers?
Yeah, my little clicker. So why, if all those folks are in Reston, why are we in Philadelphia? That's a major question that I always got. So next. So here is a modern fairy tale that will answer that question for you. And I'll read it to you as we go through this. Once upon a time, a long time ago, there was a smart young insurance executive who was hired by a smart radiation oncologist to be his departmental administrator. Next. Soon the smart young radiation oncologist had a great idea and said to the young hospital administrator, I understand the federal government is making lots of research money available. Why don't you get some of it and we'll figure out what we can do with it. Next. And so the smart young hospital administrator wrote a grant, and much to the surprise of everybody, he got some money. And the same smart radiation oncologist said to the smart hospital administrator, let's find out how others are practicing this specialty, and then maybe we can help everyone do it better. Next. And so the smart young hospital administrator put together a program of national surveys to find out about this. But he also realized, being the smart hospital administrator, that he needed to find a more neutral place to park his money as opposed to the institution for where he was working, to get it away from the hotbed of academic medical center competition. We know about that. Next. And then someone said, the ACR is a great place. They're always looking for money. So the smart young hospital administrator became a smart young association executive and started getting his paycheck from the ACR. That's the story of the start of the Philadelphia office and the Patterns of Care study, which was the first project in the Philadelphia office. And that person was John Curry. He was the director of the Philadelphia office from 1975 to 1984, and then he became the ACR executive director in 84 and retired in 2003. He was my boss. He was the one who hired me. He was a wonderful person and a wonderful boss. He was greatly committed to clinical research and improving the life of cancer patients throughout the country. And the smart radiation oncologist was Simon Kramer. He was the chairman of radiation oncology at Thomas Jefferson and one of the pioneers, really, in the development of the specialty of radiation oncology, along with Gilbert Fletcher, and I just blanked on the other one I wanted. And anyways, the founder of the RTOG. There were about 3 or 4 radiation oncologists who were the real pioneers in starting the specialty of radiation oncology as it broke away from diagnostic radiology. And Simon Kramer was one of those. So with that background, let's look at some historic milestones for the Philadelphia office, all right? 1974, as I said, it was established as the Administrative Center for the Patterns of Care study with 7 people and $500,000 in funding. Next. In 1976, Dr. Kramer had already gotten a grant funded through Jefferson to start the RTOG. And everything was going so well with the ACR, they decided to move that grant to the RTOG, and it came in 1976, all right? In 1982, RTOG statistics, which had been being done at Harvard by a guy named Marv Zellen, Dr. Paycheck came and established the RTOG Center here. Next. Through 1985 and through 96, there were various RDOG projects. Who's heard of RDOG? Yeah. It wasn't really a dog, though. People used to say, boy, this project is really a dog, huh? And that stands for Radiologic Diagnostic Oncology Group, and I'll tell you a little bit more about that next. And then ACRIM was funded in 1999. Next. And so in 2003, at the time this slide was made, funding for the office was $54 million, a lot more than the $500,000 with which we started. Next. And 118 staff. So the total funding that had accumulated through the office during the period 74 through 2001 was $370 million. A lot of money. The original office at Jefferson was in a small townhouse building somewhere around Jefferson. John Curry asked me to go and take a picture of it, but he couldn't remember where it was. That was another presentation, but they were there a short time, and then the office moved to this building, which is at 9th and Chestnut. That was the Philadelphia Federal Reserve Bank building, and we were there for, I'm not sure how many years. Anne Marie knows.
We moved down in 87, and I think they occupied it probably 1980 or 1978 or 79.
I never went there, but I'm told it was a wonderful building, and the conference room was down in the basement in what had originally been a great big vault where they stored gold bullion. All right, next. And then we moved to 1101 Market. This is the Aramark building. This is the reason I'm so fat. Because if you know your Philadelphia geography, you know this is right adjacent to the Reading Terminal Market, and we used to get lunch there every day. Okay, next. So after 17 years in that building, we were not able to renew the lease. Aramark, who was the major tenant of the building, had the top floors, 16 through 30 something. They were the major tenant, and they had the right to grab any space that became available, and they had actually over the years been metastasizing down the building, taking over more and more space. So they basically said, we want your space, and we had to leave. We didn't want to leave. It was a great So we moved to this building, and here's Anne Marie sort of supervising everything that we had to do to move into this building. We got a really good deal on that space. We got to build it all out. Anne Marie did yeoman service in getting us to this building. And I should say at this point, when I came here, Anne Marie was my administrative assistant, and over the years has progressed and assumed more and more responsibilities. And I guess of all the people in the room, you've been here the longest?
The entire ACR.
Not just Philadelphia. Thank you.
But no, I remember, just briefly, I remember IT. We hardly had any IT staff back when we moved into this building.
Right.
And Janet Fuller was crawling on the floor.
Yep.
That seemed like anything. Yeah.
Right. Janet and I crawled in and plugged in computers and everything together. So Anne Marie did a great job of getting us here, and she was a wonderful administrative assistant. I still remember the day I yelled at her because we had Mac computers then. I'd never had a Mac, and I didn't know how to get the floppy out. Yeah, you remember floppies? Yeah. So I couldn't get the floppy out, and I yelled, and I cussed, and I said, get in here. How do you get the floppy out? You can't run it in. Well, you just jag it to the trash. You didn't do that on the PC. You pushed the button, and it came out. Okay, so we had people to move everything except my plant. I had this plant I loved, and it couldn't be moved, so I got a handcuff, and I rolled it from 1101 Market. And I'll also show you this picture. This is a cell phone picture.
Oh my God.
Look at that. Look how much cell phones have improved.
It was like the first X-ray.
Okay. So the research projects in Philadelphia that we talked about are the three you see there. The Patterns of Care Study, I'm going to tell you more about that, RTOG, and Akron. So this was a slide I used to love to show. If you look at the top 60 institutions that got money in 2003, number one was MD Anderson. This is money from the National Cancer Institute. Next was Fred Hutchinson in Seattle, the Mayo Clinic. Now this is not, I ain't going to show you all 60 of them, so you can relax. But here are a few of them. UCLA, and look, ACR was number 15 out of 60 institutions with $40 million. Then I used to work at Georgetown University in the Lombardi Cancer Center, and I always like to say that and kind of say, da-da-da-da-da-da, we got more money than you. So I always felt it was important to know that the ACR is a significant player in the nation's cancer research efforts. At that time, it represented 33% of total ACR staff and 50% of the budget. I don't know if that's still true. At that time it was. Anyway, so this is sort of a disclaimer. A lot's changed since then. And you really can't compare what I'm showing you to what you have today. So let me talk about PCS, the first project that came to the office. It was a set of national surveys designed to measure the structure, process, and outcome of care given to radiation oncology patients. How do you do this? From the structure, that's the resources available to provide the care, the equipment, the staff, and so forth. The process is the actual treatment provided, and the outcome, of course, is what happened to the patients. Next. So how do we do this? For structure, this was a mail survey that went to every radiation oncology facility in the country, asking questions. What kind of equipment do you have? What kind of staff do you have? What kind of treatments do you provide? We got a 92.8% compliance rate. And then from that, we drew a random sample, a stratified random sample of institutions and sent somebody to that institution to actually collect information about the care that was provided. And that's the project that brought us Irene Mayon. Is she here?
No, last minute change.
That's her. Irene started for us as a site surveyor. Were you a site surveyor? Yeah, I thought you were. Anybody else? And the rest is history, right? And then we collected outcomes by follow-up email questions. Mail questions. So in 2003, by that time, the whole PCS project has done 6 of these surveys. It's been to institutions all over the country, many times, 59 institutions, and then we submitted renewal grants. Go ahead. The bottom line is that the grant was not funded. Although there were a few other small projects, by the 2005, PCS had run its course. Mr. Curry told me it was a great project, but it had served its time, and it was time to move on. So it was not, but it did make a very significant impact on the practice of radiation oncology. People still talk about it. So here's some proof of that. Here's some publication information. 55 manuscripts published since '94. Special edition of Seminars in Radiation Oncology. I believe there is a picture of that on the board in the office, and a lot of oral presentations. Next. Here's some publications of some presentations in 2002 Astro, 2003 Astro. A very good publication record. Everyone wanted to see, and this was considered to be important science in the practice of radiation oncology. Next. So now we come to the RTOG, and I know now that it's not RTOG anymore. It's called NRG, I think.
Yep. Energy.
Energy?
Like we have a lot of energy.
I know you do. I've seen you do. Listen, a lot of people in the ACR have taught me a lot of things. But I want to tell you, Captain Winter has taught me the greatest skill I have.
You can do it.
I can do it. I can do YMCA. Oh, that's going to cost you guys. Okay, next. So at the time this flag was made, there were 34 full members, 215 affiliate members. We had 42 protocols open, 3,000 patients a year, and 73 protocols involved. I have no idea what that kind of data is now. And maybe we can talk about that later. Here's some accrual information going back to 1994 to 2003. All right. And since its inception, again, this is 2003 data, RTOG opened 271 protocols, put on 56,000 patients, and had over 700 publications. A very, very important part of the cancer research effort of the country. Here's some more data on publications. Go ahead. That's enough, all right? I'm getting hungry. This is a slide I took from Dr. Pajak that was used in the RTOG site visit that lists these studies that contributed, these 7 studies that contributed and changed the practice pattern of radiation oncology. And I'll let you read those. This is from the New England Journal. This was the lung study headed by Dr. Cooper at NYU and Dr. Pajak. Next. The RTOG leadership, of course, Dr. Curran is still chairman. He's now at Emory. We all know that. Done very, very well at Emory. They just got their core grant for their cancer center. The big achievement for our cancer center. The prior investigators were Dr. Kramer, that I mentioned. He was followed by Dr. Luther Brady, who was the chairman of radiation oncology at Hahnemann, over that way a bit. So it stayed in Philadelphia for quite a few years. And then he was succeeded by Dr. Jim Cox at MD Anderson. And unfortunately, Dr. Cox died just about 4 or 5 months ago. Dr. Pajak and I went to Houston to his funeral. He was a wonderful man, a wonderful leader of the group. So let's now move on and talk about the radiologic diagnostic oncology group, the RDOGs. The RDOG was, this is a new slide. If it's this color, it's a new slide. A filler. The RDOG was a series of 5 individual projects, individually funded grants to examine the best way to image or manage a cancer of a specific disease site. Dr. Barbara McNeil at Harvard was the principal investigator of all of these grants, but each one of them had a separate study chair. They were all different grants. They all required setting up a new structure every time one of them was funded, and all the statistics on this was done at Harvard. So next, we'll go through these very quickly. RDOG 1, Part 1 was a prostate study that put on 808 patients, and it was at these institutions. It was a very successful study, published in the New England Journal. Next, RDOG 1, Part 2 was a lung study, these institutions. Next, RDOG 2, different grant now, was a colorectal study with 481 patients at these institutions. RDOG 2, Part 2 was a pancreas study, 189 patients, again a different set of institutions. Next. RDOG 3 was a head and neck study, only 3 institutions participated in that one. Next. RDOG 3 was a I always have trouble saying this, musculoskeletal study, 367 patients at these institutions. Now we come to RDOG 4, pediatric neuroblastoma at these institutions. And RDOG 4, Part 2 was an ovarian study with 349 patients. And then we come to the granddaddy of them all. RDOG 5 was the breast study comparing core needle biopsy or fine needle aspiration against open biopsy of breast lesions. So here's a little bit more on RDOG 5. It was a separate grant, only one part, and the study chair persons on that was Etta Pisano and Laurie Florida. Remember that, Etta? We went to, we had several meetings in Boston with Dr. McNeil getting this study together. I remember that well. It snowed one day. So the RDOG project, this is the grant information on that. I just got that off the internet next. Here's one of the major publications from RDOG 5 from the PubMed. This is the abstract on it, and this was published in Cancer in 1999 with Dr. Pisano as the lead author of it. So, hold that a minute. So we had now 9 RDOG projects. Each one of them was a separate project. And the feeling was there's a lot of wasted motion getting these groups together. We needed a group in existence that could begin to do imaging studies. And so as a result of that, next, the NCI in 1998 put out a request for application to form a new cooperative group. The ACR submitted and was successful. And so that's the foundation that led to ACR. It was funded in 1999. The first trial opened in 2000 with 100 institutions, and then the grant was refunded in 2004. That was the history of what led to ACR. Next. Dr. Hillman was the first chairman. It was Mitch Knoll, now the chairman, and the statistician was Constantine, who had moved by that time, moved to Brown. Again, we're back to 2003 data. 13 studies were opened, 2 closed, 3 completed, and so forth. Okay? Now, Akron got 2 supplements for the big studies. Akron 6652, DMIS, Dr. Pisano is the chair, and before the CT lung screening study with Denise Everly at UCLA as the chair of that. Here's some information on DMIS. You want to do this, Ed? The study opened in 2001 and it closed in 2003. We were putting it at its prime, we were putting on 150 patients a day. It was all web-based. I'll come back to that. 49,000 patients were accrued. The target was 49,500. We went 116 over. Okay. And then the lung screening study was a collaboration with I don't remember what this means. Prostate lung and colorectal group. That was to be a 50,000 patient study total. Akron was going to put on 20,000 patients. Patients were randomized to chest film or spiral TC and screening for lung cancer, and they were collecting sputum samples. I was always glad I was not a sputum sample collector. And we completed it with 30,000 patients. And I always added this one. It was the world's most complex clinical trial. Just recruiting patients to go on the trial was a major problem. I built the budget for this. And I literally, of course these were old computers, I literally had to get 2 monitors so I could spread the spreadsheet out over the whole thing. It was quite something. So this is an organization chart. I'm not going to go into all that, but I want to show you a couple of pictures of the organization chart that came from another presentation. There's Steve. Look at young Steve. Steve was the chief operating officer and a wonderful, wonderful helper to me. I couldn't have gotten along without him. Next. Janet Fuller. Janet Fuller was personnel and finance. Janet Fuller was, I think, 6th or 7th person that John Curry hired when he established the office. I was here until everybody loves Dr. Pajak, right? Dr. Pajak is a great friend and a great guy, and I can't say enough. Unchanged, huh? Unchanged. And Gene Owen was the head of the Patterns of Care study, Dr. Gene Owen. And she ran that for pretty much its whole life after John Curry left. also a great queen. I didn't have a picture of Cynthia, but she ran the Washington, Wisconsin office. Cynthia came to work for us for RDOG 5 and got RDOG 5. And I wanted to show this picture. And I had trouble with this. Joanne Steph was the Director of Data Management for a very, very long time. She was probably the hardest working person I have ever known. She got to work at 5 in the morning. She left at 9 at night every day. And you're shaking your head in agreement. And when she left to go home, she pulled a little cart with her that she had charts in that she worked on when she got home. She just lived over on Chestnut Street.
Patient chart.
Patient chart.
That wouldn't happen.
Oh, yeah. Do y'all know what charts are? We used to have paper charts. And we used to have one whole hell of a lot of file cabinets. And that's all gone.
They're totally anonymous.
Go back. So, I didn't really think about it. Should not, no. I'm glad you said that. So she used to take things so much back and forth in her little cart. Every year we had to buy her a new cart because the wheels wore out. I'm not making this up. And she retired after we moved to this building. And then 2 years later, she contracted ovarian cancer, and she died. And it's the saddest story. This woman gave her whole life, really, to this office and to clinical trials and improving the lives of cancer patients, but she was not personally able to benefit that. And I always had a soft spot in my heart for her. And I just thought this would be a good time to recognize. Okay? So finally, the ACR Philadelphia Office took an aggressive position early on to collect clinical and image data by the internet in its very early stages. Now look, you all know what the internet is, and it's really wonderful and great, but it wasn't that way a long time ago. And we made a commitment at the time after it started that it was going to be a paperless clinical trials group. Which we thought was a great idea because it said we had all these charts everywhere. One of the problems with charts was finding them. So they were always people running around, where's that chart? Where's that? Okay? So, this is old data. I don't know what you have now, but we did a critical trials management system that was turned on in '99, and it ran the holding data collection system and provided our web interface. Next.
Yep, it's still here.
Is it still here?
Yeah.
Okay. I make no comment on that. Preview 32 was the image collecting system, and it automatically received images from institutions, and they came into our imaging archive. Next. So we submitted a paper to this group called Computer Assisted Radiology and Surgery. All right. And here's the first slide in the submitted paper, the presentation that was accepted. This meeting, you may have noticed, was in Paris, by the way. Let's go back. Huh? Here we go. So Rex Welch, who was a consultant that led a lot of this effort that revitalized our whole computer system and moved us from the DEC-VAX to PC-based systems and enabled us to get the clinical trials management system, enabled us to get Preview 32. He was the prime author on it. Brenda Young, Fish, Irene Mayon, Sophia Sabrina, and Constantine, and Ella Fazana was on this. I tried to get Rex to go to Paris and give this presentation, and he wouldn't do it. So, I reluctantly. It was a great trip, let me tell you. Okay, next. So, So I'm just going to show you a couple of slides from the presentation, not the whole thing. So I went through some information on DMIS, comparing digital plain film, collect images electronically by the web, collect clinical data also by the web, and some quality assurance lists. So this was the clinical data system, okay? We designed web-based forms to do this. We simply had to be quick and easy to use. Next. The first attempt to do that wasn't very successful. And people had trouble connecting to the internet and getting all the stuff in. It didn't work very well. Next.
We still do.
So we went to a second attempt. Go ahead. Figured and physically took them to the institutions participating in these. We sent people out with these computers and set them up, go ahead, on their network. Do that. Next. All right, so that was just kind of the background of what we did to tell all those wonderful people in Paris who really didn't want to hear this because they wanted to go out and have some different food. But anyway, there were two speakers before me on this presentation. One of them got up and go back. There we go. And one of them got up and she very proudly reported that they had collected 20 images from another institution in their consortium. And they thought that was great. The second got up and she reported they had gotten about 120 images from 4 institutions in their consortium. Now this is leading edge stuff. This was 1999, I think, I can't remember, but it was a long time ago. Next. Okay. So this is my slide. Our web-based patient entry and data collection system was going very well. We've got good data, and we had gotten images on over 7,000 patients. And everybody in the audience kind of said, wow. It was really quite an achievement and one that I was very proud of. All right, that's the end of that. So I always like to end my presentation with what I call concluding interesting facts. 3% of adults with cancer are treated on clinical trials. That's what percentage of children? Anybody having a guess? 95. Good, next. I had 70 to 90. Dr. Pajak kept saying 95. Yeah. So here's some 5-year survival data. This is a sort of amalgamation of cancer survival data comparing 1995 to 2000. In 1995, 50% of adults survived, 50% of children. In 2000, 64% of adults, 80% of children. So significant progress, significantly more progress was made in curing pediatric cancers than in curing adult cancers. You always want to get that message that clinical trials are important. If you have cancer, you need to be on a clinical trial. You're going to get the best possible therapy. And as Dr. Pajak always emphasized, you got a lot better monitoring and follow-up. So many of you don't know this. I'm a retired Air Force officer. It's been 20 years in the Air Force. A lot of that was in what was then called Strategic Air Command. I was not a pilot. I was flight school. But this is the B-52. It was our big deterrent bomber. The years we used to have 600 of these. We're now down to about 50, I think. So I always like to say that the ACR Philadelphia Office is another squadron in the world war against cancer.